will now introduce Dr. Mickey Smith, who will argue in favor of stenting for intracranial stenosis. Dr. Smith is an interventional and endovascular neurosurgeon at Houston Methodist, the Woodlands. He graduated from UMDNJ Medical School and completed his neurosurgery residency and fellowship in interventional and endovascular neurosurgery at Case Western. Dr. Smith deserves a medal from our programming committee for stepping in at a late time for a colleague to debate the case for stenting of intracranial stenosis. Dr. Smith.
Thank you. I will attempt here to give some arguments for intracranial stenting within the context of atherosclerotic intracranial disease. We joked a little bit before this. Maybe I should have put a question mark at the end of the title for this presentation, and we'll talk a little bit why, but certainly there's a lot to do in proving efficacy of it. So, a lot of these, I started off a little bit, rehashing the epidemiology of intracranial atherosclerotic stenosis and stroke, but this has been talked a lot about earlier. Suffice to say that atherosclerotic disease in the intracranial space is a large driver of strokes, and especially recurrent strokes, and even in specific populations. So these studies have been talked about a lot, especially this landmark Sampras study with Dr. Chimowitz earlier, and now Dr. Ponchal earlier. Other studies that can help to validate the findings of Sampras can include these VISIT and CASIS studies, and this WEAVE study we'll talk about in its follow-up. So we know the results from the Sampras study. We do know that medical management for upfront intracranial atherosclerotic disease seem to be safer and less rate of recurrent strokes. And other studies seem to validate this or reinforce these studies. There's a VISIT trial which used actually a different stent compared to the Sampras stent. The stent used in the Sampras was specifically the Wingspan stent, which has been around for a while and used judiciously in that study specifically. VISIT attempted to maybe answer the question, is there a difference with a balloon expandable stent? But it had a lot of very comparable inclusion criteria, and the medical management was on par with the Sampras study. Those findings did essentially reinforce it. And they extended some of their findings out at 30 and 90 days. The rate of any stroke or TIA was significantly lower in the medical management group. The CASIS was a large Chinese open-label randomized study. Once again, using the Wingspan stent, they tried to parse out a little bit, because we'll talk a little bit about the criticisms of Sampras, but they waited 3 weeks after a qualifying event to treat patients with interventional therapies, and they also tried to exclude strokes, recurrent strokes caused by potential perforator circulations. But overall, and maybe thought with more selective patients in their study, they did report a lower rate of, again, any stroke in both groups. But was there a significant difference in stenting? There wasn't. So one of the criticisms of potentially of the Sampras trial was the use of the Wingspan stent, and not with its full-on FDA indication, and maybe the timing and usage and placement of the stent. So this WEAVE trial was a post-market surveillance study by Stryker to really evaluate the peri-procedural complication rate from the Wingspan stent system, and maybe its long-term efficacy and follow-up analyses. And their primary endpoint was to evaluate for any peri-procedural stroke or death rates within 72 hours after the stenting procedure. Their indications were in line with the HDE FDA-approved use of the Wingspan stent, which were only to be placed in patients with greater than or equal to 70% stenosis. And for them, they wanted to treat patients who have already received sort of the quote maximal medical therapy, those patients with recurrent strokes, 2 or more in the target territory. And as well to allow patients somewhat of a recovery after their index event by not stenting earlier than 7 days or 8 days, and actually. And what they found was it's relatively safe procedure to stent this early. And there, only 2.7 of the patients had primary events of a stroke. And that was a little bit significant because one of the criticisms, again, of the Sampras study is a lot of the operators, the interventionalists, may not have been experienced. A lot of the usage of the stents in that system or in that study, sites had, made perhaps less than 10 cases with the wingspan stent before using them, and the weave had a little bit more criteria and operators who are more experienced with placing these type of stents. Overall, though, some other criticisms of the Sampras study, which the weave attempted to answer, was the high complication rates, which were largely, again, peri-procedural related. Was this due to those patients who were allowed to receive a stent maybe in less than 7 days? Was a potential question, or was this largely operator experience? And finally, I think one of the major criticisms of these medical management versus stent studies is a lot of them, like Sampras, their primary endpoints were really for any stroke within a certain time point, versus any disabling stroke. And is that a difference to the patients and their functional outcomes? And I think a lot of us argue it is. So that's one of the major criticisms. So obviously, I think up front, medical management, all the data suggests, is much more efficacious than stenting. But is there ever a time to stent, and which populations would it be useful? One of the obvious choices are in patients with an acute occlusion. When we call it rescue therapy, these patients who have an acute large vessel occlusion due to likely underlying atherosclerotic disease and thromboembolism from artery to artery. These patients are those that have persistent occlusions despite mechanical thrombectomy attempts with the stent retriever or direct aspiration. And in cases like this, studies have shown recanalizing with placement of a stent has been proven to be helpful. The rate of good outcomes, defined as those patients who have modified Rankin scales of 2 or less after rescue stenting, were better in those patients who had persistent occlusions after mechanical thrombectomy, as well as those patients who were treated with mechanical thrombectomy alone but did not have persistent occlusion after the original procedure. Studies have shown technically, fewer mechanical thrombectomy passes were a good outcome, and this is in line with previous mechanical thrombectomy studies that showed fewer passes have less chance of symptomatic hemorrhage. But overall, and probably, maybe due to still slightly overall more passes that, and maybe initially related to having to load patients with antiplatelet agents on top of potentially receiving TPA and other things, the rate of hemorrhage was higher than mechanical thrombectomy alone in these patients, and more likely in the anterior circulation. But in that event, it's really a rescue effort, and that's, I think, at this time, the most common usage of intracranial stenting. So what are the other indications? And so the follow-up to the study of the Weave trial showed that at 1 year, patients who did receive a stent actually had less recurrent strokes, 8.5% of those patients, compared to the aggressive medical management arm after 1 year in the Sampras study, which was, I think, 12.2%. So I think that data alone does show some evidence that with on-label recurrent strokes, intracranial stenting can be helpful, and there may be a significant difference compared to those patients who didn't get it. Other patients who might benefit are those patients who, again, have the recurrent events but really exhibit hemodynamic compromise, or are those patients who may benefit who are with recurrent strokes in a non-perforator territory. There's studies, and the Weave trial looked at this as well. Stents placed outside of a perforator territory seem to have better outcomes. And this may be related to the degree of angioplasty within the stent, or trying to reduce and minimize the so-called snow plowing effect into the perforating arteries. And otherwise, in patients who may be a poor candidate for bypass, who are not otherwise fully occluded. That's a future direction to look at for the efficacy of stenting. So what do we need to prove that stenting can help? You know, we need trials with primarily endpoints of not just for any stroke. I think we should have trials that with primary endpoints of disabling or fatal strokes. Further studies, some studies have showed that drug-eluting stents and drug-eluting balloons have less rates of recurrent stenosis, but is it less rates of symptomatic recurrent stenosis? I think more information needs to be sent with that. Currently in the US, we don't really have any on-label or HDE stents other than the wingspan, and most of us who want to use a drug-eluting stent use coronary stents. And other technical considerations to reduce periprocedural risks or future strokes can include avoiding angioplasty at perforator sites, again, avoiding these snow plowing effects, and just the technical use of less exchanges, less wires, balloon-mounted stents is one direction technically to look forward to as well. Okay, so that was my argument potentially for intracranial stenting.